Hello and welcome.
Today
our group will be presenting our project titled Surgical Site Infection Rate Reduction, Post-Total Knee and Hip Replacement. Our presentation is divided between our 5 members, with each member covering one of the first 5 marking criteria for Assessment 2A and 2B, as well as a brief discussion on our delegated outputs. I will be covering marking criteria 1, which will include the introduction and explaining what our project is about. I will also briefly discuss my allocated output of preoperative patient optimization and an enhanced recovery after surgery or ERAS document package. Tina is covering marking criteria 2, communication strategies to key personnel and stakeholders, and the data collecting system to track surgical site infection rates. Amaria will be covering criteria 3, potential project costs and financial implications, and discussing a local antimicrobial formulary and restriction policy and procedure. Sherry will be covering criteria 4, identifying potential issues and management strategies, and introduction of a skin preparation procedure. Finally, Raymond will be covering criteria 5, relevant policies and standards that align with our project, and his output of an audit schedule. Raymond will also conclude the presentation to improve the continuity and flow. Surgical site infections are the most frequently occurring complication for all surgical patients worldwide, and are responsible for increasing length of hospital stay with a $10 billion impact globally. As the title suggests, our project is aimed at reducing the rate of surgical site infection after both total knee and hip replacement. The rationale for our project is that an aging population, combined with factors such as osteoarthritis, sports-related injury, and obesity, will result in higher volumes of total knee and hip replacements being performed by the year 2030. Data shows that the most commonly occurring and preventable complication linked to increasing costs for total joint arthroplasty are surgical site infections, costing an estimated $97 million. If healthcare facilities can reduce the rate of surgical site infections from 5% to 2%, it will result in a saving of $61 million to the Australian healthcare system. As surgical site infections occur after all surgical procedures, our group decided to refine the scope of our project by focusing on the two most commonly occurring joint arthroplasties, total knee and hip. In 2018, there was a 125% increase in total hip and a 156% increase in total knee replacement surgery since 2012. By 2030, they are projected to increase even further to 208% and 276%. The goal of our project is to reduce the rate of surgical site infection, post-total hip and knee replacement from 5% to 2% by the 30th of April 2026. Our objectives are to decrease average length of hospital stay to the national average or below, which is 4 days, by the 30th of April 2022. To decrease surgical site infection rates to the national average or below, which is 3%, by the 30th of April 2022, as well as to report surgical site infection rates post-total knee or hip replacement quarterly, aligning with senior management and medical advisory committee meeting. For my output, I researched ERAS guidelines for total knee and hip replacements. Preoperative optimization focuses on improving a patient's health and fitness prior to surgery to improve post-operative outcomes. Non-surgical interventions will focus on preoperative patient optimization, focusing on diabetes, mellitus, tobacco cessation, and obesity, as well as managing any pre-existing anemia or malnutrition. This will be achieved by using pre-existing physiotherapy staff and facility gym equipment to coordinate and run preoperative exercise programs in conjunction with pre-existing clinician nursing, clinician staff, and general practitioners to manage patient comorbidities, as well as to educate patients and manage patient expectations. Intraoperative and postoperative treatment will be standardized for all patients undergoing total knee or hip replacement, with a facility document package creating guidelines for both surgical, anesthesia and nursing management based on the ERAS principles. This is included but not limited to preoperative fasting, anaesthetic protocol, tourniquet use and surgical technique, post-operative medication regime, as well as post-operative nutritional care and early mobilization.
To have an effective system for prevention of surgical site infection, it requires risk factors to be reduced and to optimize evidence-based processes of care. The project personnel is to have an effective system and group of healthcare professionals to prevent surgical site infections. Groups cannot always predict when patients develop surgical site infections, therefore we can learn from them and improve management to have a structured approach to investigation, which is the purpose of this project. To prevent surgical site infections, the perioperative team should have a structured approach to investigate the surgical site infections at an early level and develop a plan of attack to address contributing factors. To reduce the rate of surgical site infections, a structural approach is required to investigate infections at a system level and develop strategies. For this project, a surgical site investigation tool has been introduced. The project team should investigate many surgical site infections as required. A team member will abstract information from patients' charts and present it to the group for their status. The purpose of this tool. This tool will help your safety program team understand lapses in infection prevention process that may have contributed to surgical site infection cases. It can help your team identify practice patterns and inconsistency with practices, so you can be more easily pinpointing opportunities for interventions. Each hospital will have an infection review process and should be embedded with each process of this project. The data table being used within the project is shown on the next slide and will be explained. On this slide here, surgical site infection data table, there's two examples of the table listed here, the pre-op wash and antibiotic. The data audit table has a 4-page Microsoft Word document which contains information such as patient, reason for admission, previous surgeries, the surgeon involved, their medical history, diabetic history, if applicable. On this slide here, we've put the two main points of pre-op wash and antibiotics. We would like to investigate which skin preparation was used, who applied the skin preparation, and any other assistance required for this preparation. If so, we would like to be explained further. With the antibiotics, we want to know different surgeons' approach. Are they using one type of antibiotic, two types of antibiotics, what time the antibiotic was administered? Also, with the surgeries involved, we would like to know the case duration, the time of incision and completed, and what time was the antibiotic redosed if indicated, which will help us track any patterns or pinpoint any issues involved with the surgical site infections. Communication strategies is a key part in this project. Communication strategies will involve many platforms to stay updated within each healthcare professional involved in the project. Routine audits and data collecting table to track each surgical site investigation will be required throughout this project. There will be an assigned project manager, which their responsibility will be for guiding all aspects of the project, including the communication management plan. Specifically, the communication will include the method frequency, which will vary depending on the project demand. Part of this communication plan is to make a standard platform for the reporting process to stakeholders. This will help enable a consistent communication platform. A template is shown in the next slide to display how communication will be shown throughout this project. This slide here is Communication Table for Surgical Site Infection Project. The table involves each person involved with the project, such as our stakeholders, our sponsors, our project team, and all parties of interest. Which information will be required for these people being involved, as you can see in column 2. Each one is a bit different. The frequency being needed to contact each person. So weekly will be obviously for the project team, as you can see there, who will be regularly updated. How will we communicate with these people? Will be by written reports for the sponsors, phone calls or emails, regular meetings and newsletters for all the people of interest of this project. Communication strategies within the group outputs will be broken down with the requirement of frequency and platforms used. Excel, files, Zoom calls and emails and phone calls will be the main communication strategies used within this project. Excel files will be the main one to document all surgical site infection information. Communication will be shared with the required health professions such as the ones listed in this slide.
Our project goal is to reduce the rate of SSI post-total knee replacement and total hip replacement from 5% to 2% by 30th of April 2026. Therefore, looking at the table, our project budget allowance was divided into 5 years. This is including the project budget contingency allowance and in-kind cost. We costed the following: labor costs, operational, capital, and evaluation cost. Since this is a big project, we included the internal evaluation cost and external evaluation consultant. Our project outputs are costed and reflected in the table. This includes as well estimates of ongoing cost of supporting the project outputs, which is often overlooked. Our project total budget allowance is $1,346,122.45. Our overall project cost allowance, including in-kind cost, is $1,481,672.45. Our project's budget and expected expenditure ensures that our outgoings will not exceed our incomings. When we planned this project, we thought about it from start to finish. We were realistic and covers all the major areas of expenditure. We identified and summarized our project budget and expected expenditures in line with the project plan and financial planning. The budget information reflects the funding for the life of our project in each single financial year. The antimicrobial formulary should be appropriate to the needs of the hospital and should take into account the range of antimicrobials required, the clinical orientation of the hospital, and local antimicrobial resistance. It should also be updated periodically and compliance with it audited. The restriction policy and procedure is important because it outlines the essential elements of the hospital and the key requirements for antimicrobial prescribing, use, and management in the hospital facilities. On the other hand, standardized form is required carefully and clearly, like the protocols and expectations of hospital, adhering to the specified steps in the standard operational procedures and uniform application of the evaluation tools.
Hello everyone, I'm Sherry and I will be discussing the risk management and evaluation process of our project. Similar with many projects, we too have identified some risks that may negatively impact or delay our project objectives. We have adapted this project-specific process that is aimed at controlling and reducing these risks. It is crucial that we identify them early on. This way, we can lay out workable strategies to mitigate them, and furthermore minimize their impact on the completion and success of our project. Some of our identified risks are listed on the screen. Each one will be assessed against the risk matrix probability rating adapted from PRINCE2. Mitigation strategies are also shown. Our project risk register will allow us to continuously review and reevaluate these risks throughout the length of our project. This will ensure that the project goal and objectives can still be met. Subsequently, opportunities and errors may arise, and these may not be in the direct control of the project team. We have identified some issues with the respective workable strategies. Identified issues include a break in communication, expectations of the sponsors and the stakeholders, patient access to the program, and patient compliance. Consequently, workable strategies include a well-defined communication plan, ongoing meetups with the key stakeholders, a clear patient inclusion and exclusion criteria, and our tracking tool. Every issue that arises during the course of the project will be logged. It will have an identifier and assigned accountable team member, and actions that have been done will be documented. And this concludes our risk management strategy. Now I will briefly discuss our evaluation process. Planning for evaluation at the start will aid us to determine effective methods of data collection and feedback. It may also assist in highlighting relevant organizational standards to capture the interest of our stakeholders. Firstly, a process evaluation will be formulated to identify gaps for improvement of our outputs as well as their strengths. These would include patient satisfaction reports pertaining to the new perioperative education and exercise program, feedback from staff about the new enhanced recovery after surgery procedural document, as well as the new skin prep technique, feedback from stakeholders and whether problems are addressed in their point of view, and identifying effectiveness of our tracking tool and compliance audit to recognize whether the project is operating as intended. Then, an impact evaluation will be done to determine whether the goal and objectives are met. It will answer the questions by April 2022, has there been an improvement on the length of hospital stay and what is the current average? Also, is the facility's surgical site infection rate following a total hip and knee replacement in par or below the national average? And finally, at the conclusion of our project in April 2026, has the SSI rate following a total knee and total hip replacement been reduced to 2%. Long after the project is completed, an outcome evaluation is ideal. This will record and monitor long-term benefits of the project. These two quantitative data will be used: percentage of SSI complications in the selected population and the cost of care of each individual patient, including readmissions due to complications. And now I'll present my output: a new skin preparation technique to maximize the infection prevention following a total knee and total hip replacement. The role of skin preparation in joint surgery cannot be overlooked. An extensive literature review will be conducted and an in-house randomized trial will be done to evaluate its benefits in comparison to the current one. In selecting the best technique, other closely related factors will be considered. These include drape adhesion, convenience of application, time, and cost.
Hi, I'm Ramon, and as mentioned by Ashley earlier, I will be discussing about the various standards which our project is aligned with. The first clinical standard that I would like to discuss is a standard on clinical governance. There are many layers and points of discussion about clinical governance, but I would like to mainly discuss the connection between clinical governance and our project on decreasing surgical site infections amongst those who have had total knee and total hip replacements. According to the Australian Commission on Safety and Quality in Healthcare, clinical governance key responsibilities for preventing healthcare infections are as follows: create and enforce governance frameworks for healthcare-related infections and antimicrobial stewardship, establish and enforce antimicrobial stewardship and healthcare-associated infection policies and procedures, recognize, manage, monitor, and review risks associated with healthcare-associated infections and antimicrobial stewardship using organization-wide risk management systems, and to deliver or provide access to training and education. Hi, I'm Ramon. The second clinical standard that I would like to discuss is about partnering with consumers. This clinical standard highlights the fact that we need to work with patients with regards to the decisions they make in their own care. This entails for healthcare workers to involve patients in all aspects of their care, including those that help prevent hospital-acquired infections. For total knee and hip replacement patients, education, and as mentioned in the previous presentation by my colleagues regarding pre-operative optimization, patients get a good glimpse of what their care is going to be like perioperatively. Expectation settings and a clear explanation of how their surgical journey would be like is a means of achieving great partnership with consumers, or in this case, post-total knee and hip replacement patients. The third standard is preventing and controlling healthcare-acquired infections. The key points regarding this standard in relation to our project is the prevention of surgical site infections, particularly in hip and knee replacement patients. Prevention or prophylaxis is achieved by a multifaceted and complicated system which starts from the assessment of patients prior to their surgeries. The therapeutic guidelines are what surgeons use to administer prophylactic antibiotics to their patients prior to incision, intraoperatively, and postoperatively. Surveillance of surgical site becomes routine practice for all nursing staff who will be looking after patients postoperatively. These principles are all embedded in the hospital policies regarding infection control, medication administration, detection of sepsis, and post-op monitoring of orthopedic patients. This slide is my output for our project, which is the routine internal audit schedule for our project, which focuses on surgical site infection rate reduction, post-total knee and hip replacements. This next slide is a sample of the progress audit for all our project phases and activities, including preoperative education, a facility document package, skin prep procedure, a local antimicrobial formulary, and data collection tables to track SSI rates. This slide is just a continuation of the previous slide. It contains key project issues, key project risks, communication, and basically what we've accomplished for the last period, the tasks that we need to finish for the next period, the total number of knee and hip replacements for the month, the reported infections for the month, and the rate of infection. This is our auditing schedule, and it's mainly a retrospective surveillance. These cases are entered into a database, Excel file, and is audited with progress notes, incident reports, and pertinent documentation monthly by the allocated auditor. The audits are done monthly and are communicated via email to all stakeholders of the project. Interventions are discussed in the department heads, orthopedic surgeons, and infection control associates meetings. In conclusion, we discussed what our project is about, and that's on reduction of SSIs for total knee and hip replacement patients, our project goal and scope, our pre-operative patient education exercise program, and our eras, our communication strategies to key personal stakeholders and project personnel, data collection table to track surgical site infection rates, project costs and financial implications, an antimicrobial formulary, identifying potential issues and strategies, skin preparation procedure, relevant standards that align with our project and conclusion. That's the end of our presentation. Thank you.